Hello, I'm Dr. Zakhour. I'm an assistant clinical professor at UCLA in the Division of Gynecologic Oncology in the Department of OB/GYN, and today we'll be talking about cervical cancer prevention and management. You can ask questions on Twitter using the hashtag UCLAMDChat or comment on YouTube. Today, our discussion points will include the incidence and risk factors for cervical cancer, as well as prevention methods, including Pap testing and HPV testing, as well as HPV vaccination, and the management of cervical precancers, also known as cervical dysplasia. We will talk about cervical cancer diagnosis and some treatment basics, including new treatment strategies. And anytime you see this what's new posted here, that means I'm indicating data that has come out within the last 5 years. So just some basic anatomy. Today we'll be focusing on the cervix, which is the lower portion of the uterus. And when we talk about lymphatic drainage of the cervix, we're really focusing on these pelvic lymph nodes that are shown here on the right. To just go over some basic cervical cancer statistics, this is data from the SEER database, and there's an estimated approximately 13,000 cases of cervical cancer in 2019, making up 0.7% of all new cancer diagnoses. And approximately 4,000 individuals will die from cervical cancer this year, making up 0.7% of all cancer deaths. Of all women in the population, 0.6% will be diagnosed with cervical cancer in her lifetime. And for all comers with cervical cancer, the percent surviving 5 years is 65.8%. And that is primarily driven by the stage in which women are diagnosed. So patients who are diagnosed at a more advanced stage will probably fall on the lower end, and women who are diagnosed at stage 1 to 2 have a more favorable prognosis. Looking at cervical cancer incidence worldwide, there is a disproportionately higher incidence in areas where routine screening is not available, and it is the most common cause of cancer-related death in young women under the age of 35. When we think about cervical cancer risk factors, HPV is the first thing that comes to mind. HPV is the human papillomavirus, and it is detected in over 99% of cervical cancers. HPV is a small DNA virus that has over 40 types. It's also associated with multiple other cancer types, including vulvar and vaginal cancer, head and neck cancers, anal cancers, and penile cancer in men. The low-risk HPV types are known to cause genital warts, and HPV is primarily transmitted via sexual contact, but can also be transmitted by close skin-to-skin contact. So when we look at all women in the population, about 80% of women are actually infected with HPV at some point in their lifetime. And about 7% of women will have an abnormal Pap test at some point in their lifetime. And so you can see this circle is getting smaller and smaller. About 300,000 of these women per year in the United States will have a high-grade precancerous lesion of the cervix. And about 10,000 women per year in the United States will actually go on to develop cervical cancer. There are 4 key steps in the development of cervical cancer, and the first one is infection with a high-risk HPV type. Then the virus must persist, and those persistently infected cells must go on to become a precancer. And the last step, ultimately what defines this as a cancer, is invasion of this layer here called the basement membrane. The natural history of high-risk HPV is actually primarily that it's cleared in most women within a year, so this is considered a transient infection. However, for some women, HPV will persist over the course of several years and go on to cause low-grade cervical precancers, which then change into high-grade cervical cancers, and then over the course of many years can progress on to an invasive cervical cancer. Other risk factors for cervical cancer that we know of are tobacco use, which we think is a cofactor for HPV persistence and progression. There are several risk factors that are actually related to the increased risk of HPV acquisition, so early onset sexual activity, having multiple or high-risk sexual partners, having a history of a sexually transmitted infection, and things that increase the risk of non-clearance of HPV are things that suppress the immune system. So examples of this would be the HIV virus or long-term steroid use. Patients who have a previous history of vulvar, vaginal, or cervical dysplasia are also at higher risk of cervical cancer. So Pap smears were developed by an individual named George Papanicolaou, also known as the father of cytology. And prior to the routine implementation of Pap smears in the 1950s, cervical cancer was actually the deadliest cancer in the 1930s, killing more women than breast or lung cancer. After the implementation of Pap screening, cervical cancer ranks much lower in cancer deaths. So this is a very busy slide looking at the screening guidelines that are proposed by multiple organizations, but things that are quite consistent across the board are that the recommended age of screening to initiate screening is 21 years of age, and the age to discontinue screening is 65, with the understanding that these patients need to have had normal screening tests within the 10 years prior to turning 65. So there are obviously exceptions for women who've had recently abnormal Pap smears or who have been inadequately tested within the 10 prior years. We would consider testing beyond the age of 65. So big things here are that annual Paps are no longer indicated. That's a thing of the past. And we may be shifting towards HPV-only testing in the future. The other thing that's important to know is even in women who have had the HPV vaccination, we still are recommending the same screening at this point. We are awaiting long-term data to look at how much the HPV vaccination truly decreases the risk of cervical cancer and precancer. But at this point, the recommendations remain the same, whether you've been vaccinated or not. So let's talk a little bit about the HPV vaccination. So currently in the United States, there's two vaccinations that are available. There's the Gardasil 9 and the Cervarix. The Gardasil 9 covers 9 types of HPV, including a couple low-risk subtypes, as well as the high-risk subtypes that we're aware of. Cervarix is a bivalent vaccine which covers 2 high-risk subtypes of HPV that drive the majority of cervical cancers. And there was previously a quadrivalent Gardasil vaccine that was available when the vaccines first came out, which covered 2 low-risk and 2 high-risk subtypes. So there are plenty of individuals who've been vaccinated with just the quadrivalent Gardasil. Routine vaccination is recommended for girls and boys at the age of 11 to 12, but it can be given as early as 9 years of age. And really the goal here is to give this vaccine before the first sexual encounter, to give the vaccine before the individual is at risk for acquiring HPV. The vaccine can be given up to age 26 as a catch-up vaccine, and there's some newer data that is recommending vaccination between the ages of 27 and 45, but this really needs to be individualized and is not considered a routine recommendation at this point. The HPV vaccination is safe and effective. It uses something called a virus-like particle, which is an empty capsid that resembles the virus immunologically and causes an antibody production in the body. It cannot cause HPV infection. It is safe to give in patients who are immune compromised and is actually encouraged in this very important group who are at higher risk of developing cervical precancers and cancers. It's unclear at this point if the vaccination is safe in pregnancy. We just don't have enough data at this point, so it's best to wait until after a pregnancy. But it is safe to give in individuals who are breastfeeding. And in short, this is a cancer-preventing vaccine. And as an added bonus, the 9-valent Gardasil vaccine actually prevents genital warts as well. So how do we manage abnormal screening tests? So for patients who come in for their routine Pap and HPV screening, and there's an abnormal result, we generally will follow what's called the ASCCP guidelines, or the American Society for Colposcopy and Cervical Cancer Screening. A colposcopy is a procedure in which we take a close look at the cervix in the office using a microscope, and cervical biopsies may be taken, as well as an endocervical curettage, which is a scraping of the cervical os, or the inside portion of the cervix. Some women may go on to need some excisional procedures where a small portion of the cervix is removed via LEEP or cervical conization. LEEP procedures can be done in the office. Cervical conizations are generally done in the operating room. And in terms of additional screening after an abnormal test and this initial workup, we will follow these guidelines issued by ASCCP, and your physician can guide you as to further screening after this is done. So oftentimes cervical cancer symptoms are not present at all, and this is why screening and prevention are so very important. Some women will present with irregular or heavy vaginal bleeding. A complaint we often hear is bleeding after intercourse. Some women will have abnormal vaginal discharge, and women who have cervical cancer at a later stage will often present with symptoms such as pelvic or back pain, sciatica-like pain, or weight loss. So the diagnosis of cervical cancer requires tissue. This may occur with an abnormal Pap test that leads to the series of testing that we previously discussed. Your provider, if they see an abnormal lesion on the cervix, may just go directly to biopsy. But either way, it needs to be evaluated under the microscope by a pathologist to determine the diagnosis. The most common types of cervical cancer are squamous cell carcinoma, which makes up about 70%, adenocarcinoma, which makes up 25%, and then there are some other rare types of cervical cancer that we see as well. And after diagnosis, additional imaging is often performed, usually in the form of a CT scan or a PET CT scan, and occasionally we'll use an MRI for surgical planning as well. When we think about cervical cancer spread, there are three primary ways that cervical cancers spread to other organs. One is by direct extension, which means that the cervical cancer will actually just spread into the adjacent tissues nearby, whether that's the vagina, the uterus, or the parametria. The second way that cancers can spread is hematogenously, which means through the blood. So cancer cells can spread throughout the body through the bloodstream. And lastly, cervical cancer can spread via the lymphatics. This is when we will occasionally see positive lymph nodes. And like we talked about previously, these are the high-yield lymph nodes when we're looking for cervical cancer spread to the nodes. These are the pelvic lymph nodes that drain the cervix. There are 4 stages to cervical cancer. Stage 1 is confined to the cervix. Stage 2 and 3 involves local invasion to nearby structures. 4A involves the bladder and rectum, and then 4B is when we see distant metastasis to organs that are distant from the cervix, like the lung, the upper abdomen, things like that. And stage really determines the way that cervical cancer is. Locally advanced cervical cancers, which are cancers that extend to nearby organs, are often treated with chemotherapy and radiation. And then distant metastatic or stage 4B disease is treated primarily with chemotherapy, and sometimes radiation will be added to that as well. There are fertility-sparing options for young women who desire to preserve fertility. This is primarily for stages 1A1, 1A2, and for patients with a small stage 1B1 tumor. A cervical conization, which is a procedure we previously discussed, can be performed for stage 1A1 and can actually be curative. For stages 1A2 and 1B1, we perform something called a radical trachelectomy, which means removal of the cervix as well as some of this adjacent tissue called the parametria, as well as the upper portion of the vagina to obtain a clear margin around the cancer. And a pelvic lymph node dissection is usually done concurrently. And given that these women wish to preserve fertility, we will oftentimes also place something called a cerclage, which is a permanent stitch that's used to help close the cervix to prevent early delivery and subsequent pregnancies. For women who do not wish to preserve fertility and have stage 1 disease, many of these patients are candidates for surgery. And really the goal when we're thinking about surgical management is that we would like to obtain an adequate margin around these tumors, which means that we want to obtain tissue that's nearby that does not have cancer involving it. The standard procedure is a radical hysterectomy with removal of the lymph nodes nearby. There is some emerging data on the utilization of sentinel lymph nodes in cervical cancer, which means injecting the cervix with a blue or green dye to see if we can identify which lymph nodes the cervix drains to, and removal of just a few lymph nodes on each side of the pelvis as opposed to doing a full lymph node dissection. Some patients may still require chemotherapy and radiation after the radical hysterectomy. And there is also newer data as of last year that open radical hysterectomy for these patients may be safer than a minimally invasive approach. Minimally invasive surgery is laparoscopic or robotic surgery, but there is a large amount of data that has come out recently that has shifted the way we think about treating these cancers, and many providers across the country are now offering this surgery through an open or laparotomy approach. For locally advanced disease, which is disease that has spread to adjacent organs next to the cervix, usually this is treated with external radiation, which is given over the course of about 5 weeks. Chemotherapy is usually given weekly to help sensitize the tumor to the radiation. And we usually finish off the treatment with something called brachytherapy, which is a localized radiation to the cervix. For metastatic cervical cancer, chemotherapy is usually the standard of care. Local radiation can still be utilized for patients who are very symptomatic, so patients who have a lot of pain or bleeding related to their cervical cancer, radiation works quite well for that. And another what's new here, so we have started in the last few years using a targeted agent called bevacizumab, or Avastin, which seems to work in conjunction with chemotherapy to improve outcomes in these women. For patients who have recurrent cervical cancer, so it's very important to engage our palliative care colleagues, as patients with recurrent disease will also, often have symptoms related to their disease or the treatment for their disease. And for patients who have what's called a central pelvic recurrence, so a recurrence that is localized to the center of the pelvis, who have not had radiation, radiation can be offered at this point. However, if women have received prior radiation and have a central recurrence, we may offer something called a pelvic exoneration, which is a large pelvic surgery that usually requires removal of the bladder, the uterus, cervix, and the rectum. And most women will have postoperatively a colostomy and a urostomy. If metastatic disease is found at the time of recurrence and the patient has not received chemotherapy previously, the standard of care is to give chemotherapy with that targeted agent, bevacizumab. In patients who have had chemotherapy previously who have metastatic disease, occasionally we will offer additional chemotherapy. But what's new is that we have started using this immune therapy called pembrolizumab, or Keytruda. And this is specifically for patients who have a tumor that's PD-L1 positive. So let's talk a little bit about that. But additionally, clinical trials are often available, and if we don't have one here locally, we can help you find a clinical trial somewhere across the country. Okay, so immune therapy. Pembrolizumab is a drug that is a PD-1 inhibitor, and the response rate for women who have a PD-L1 positive tumor is about 15%, which actually outperforms a lot of the chemotherapy regimens we've previously used for recurrent cervical cancer. There are some immune-related toxicities that we sometimes see along with this drug, such as rash or colitis or pneumonitis, which is inflammation in the lungs. And so what you can see here is these tumor cells express this PD-L1 that binds to the immune system T cells, PD-1. And so when you block this interaction, it kind of awakens the immune system to help work against this cancer cell. And so this is how Keytruda works. In terms of clinical trials, so clinical trials encompass research that tests for new ways to treat disease. Clinical trials are completely voluntary, so patients have to engage in informed consent. They have to understand what the trial is about before signing consent for it. Clinical trials are very important in advancing science and developing better treatments, and clinical trials are the reason that we have drugs available for this disease at this time. And so some of the pros of being on a clinical trial are that you're going to get expert care by a group of clinicians that's really dedicated to this trial, potentially more attention while you're on trial, and you may have the potential to receive a new and beneficial drug, as well as the opportunity to contribute to the advancement of science. Some of the cons are that if we don't have a clinical trial locally, you may need to travel for a clinical trial. There's also the possibility that this new drug may provide no benefit. And it may also warrant some additional visits to the clinic and some additional lab testing. So in summary, cervical cancer is a preventable disease via the HPV vaccination, as well as via screening through routine pap smears and HPV screening. Anytime you have abnormal bleeding or pelvic pain, this warrants a visit to an OB/GYN. And if diagnosed with cervical cancer, you should find a gynecologic oncologist to help manage this disease. Newer treatments are currently being developed, and clinical trials are important in getting new treatments approved by the FDA. As a division of GYN oncologists at UCLA, we are available at 5 office locations stated here, and for appointments you can call this number here. And at this point, I'm happy to take any questions. Thank you. Okay, so the first question we have here is, how is the HPV vaccination given, and are there any side effects? So the HPV vaccination is an injection that's given intramuscularly. It's typically given at time 0, and then 2 months later, and then 6 months later. So it's a 3-series vaccination. And the most common side effects of the HPV vaccine are just localized swelling and pain at the site of the injection, which usually dissipates within a few days. And some individuals will also have headache as another common side effect, but those are predominantly the common side effects that we see. The next question is, how quickly does cervical cancer develop and progress? So this is, for the most part, a slow progressing disease. And so like I showed you in one of the prior slides, we think that HPV is first acquired and then persists and causes usually a cervical precancer that is low grade, that progresses to a higher grade cervical precancer. And this process can take several years. And usually by the time we've diagnosed cervical cancer, there has likely been some abnormality of those cervical cells for 5 to 10 to even 15 years. Do I need pap smears after a hysterectomy? So that's an excellent question, and it depends on the indication for the hysterectomy. So if the hysterectomy was done for the purpose of a cervical precancer or cancer, those women will need a vaginal pap smear for the subsequent 20 years to follow. Okay. For women who have a hysterectomy for benign indications, so who do not have a cervical precancer or cancer, there's no reason to do vaginal pap smears after hysterectomy. Do you have any other questions? So thank you so much for being here with us today, and I hope you learned something valuable, and have a great day.